Hi everyone, this is a recorded lecture on the primary care approach to management of chronic kidney disease. I specifically separated out chronic kidney disease because you will see a lot of these patients in your practice, and I want to make sure that you are prepared to take care of them because sometimes they can be pretty involved, especially if they have other comorbidities. So overall, when we're talking about chronic kidney disease, we notice that there is a low recognition of this disease in our public population. So many Americans, they are lacking this diagnosis for one reason or another. Some people, they don't have a established provider, or they just don't want to go see a provider. That's very common actually where I work at in Marion. Some people are afraid of needles and don't want to have labs drawn, and then some of it falls on the actual providers. At times, sometimes we as providers aren't as diligent and following lab work as what we should be, and so then people are underdiagnosed with this problem. So chronic kidney disease, when we're talking about that, it's a term that's often used to describe many levels of decreased kidney function, and it can range from mildly decreased renal output to severe kidney failure, and we'll go through that as we get through this PowerPoint. But just understand that chronic kidney disease it's a wide spectrum basically of kidney disease that a patient can have. So when you're thinking of the leading causes of chronic kidney disease, it's important to understand that high blood pressure and diabetes are the two big ones. So if you have a patient that is a diabetic, they need to at least have a yearly complete metabolic panel, or even a renal profile if that's something that your practice ends up liking over the CMP, but they need to at least have those yearly. And the same with people with high blood pressure. This is something, again, we go back to that low recognition of CKD. We need to make sure that these people are being followed with appropriately, because more than likely, and even more so if they are not following their treatment plan, but more than likely they will develop some sort of chronic kidney disease later on in life. So what research shows us is that nearly half of all patients diagnosed with chronic kidney disease have diabetes and or cardiovascular disease of some sort. And then individuals with chronic kidney disease are also at a higher risk for developing cardiovascular disease. So, someone that, say, has a genetic condition that has caused them to have more of a chronic kidney disease, we also need to follow with them more closely, because we understand that they have a higher risk for developing that cardiovascular disease. And actually, research says it's about 70% of chronic kidney disease patients age 65 and older can develop some sort of cardiovascular disease. So what will your role as a primary care provider be as far as chronic kidney disease recognition? We want to make sure that we are able to catch those early patients, those early CKD patients, so early recognition. We also want to offer opportunity to enhance the kidney protective care by improving management of modifiable risk factors. What that basically is saying is that the risk factors that make a person more prone to developing chronic kidney disease, so these people, like what we were saying with diabetes, high blood pressure, people with a genetic predisposition, we need to make sure that we are offering them patient education and we're following them appropriately. So those are people that should be on our radar that we take a little bit of extra care for. We also want to improve prediction of incident cardiovascular events beyond just the traditional risk factors. So these are people, a person that is at risk for a heart attack, we can associate risk factors with that, but we also need to recognize that people with CKD are even more prone to having an MI event or a stroke event or something of that nature. So those are people that we need to make sure that we're following. You want to encourage appropriate and timely referral to the nephrology, and our nephrologists, we actually have really great nephrologists at Marion, and this is one thing that they say over and over, because a lot of these patients, if they had the chance to see them earlier on in their care, they might have been able to slow down the progression of their disease. So keep that in mind as well. Sometimes money plays a factor into that as well. If you look at some of the copays that these people have, to go and see a specialist. I know, that is something that we do have to take into consideration, but at the same time, it will, in the long run, save them money by seeing a specialist, because they won't hopefully have as many hospitalizations or medical bills, but also it'll give them a better quality of life in the long run. You also, you want to limit patient safety risk associated with a CKD. And again, that's just going to go back to, are we doing the appropriate lab work? Are we following with them appropriately? Really a person, if we look at the people with high blood pressure and diabetes, really those patients should be followed every 3 to 4 months. And especially if you're changing medication, it might be even sooner than that you need to have them seen in the office. So this is a nice little picture here. It just kind of shows you what are some of the side effects of chronic kidney disease. And these are important, because this is what you're going to have to keep in mind when you're treating these patients. So as kidney function decreases, the kidneys are less able to maintain appropriate fluid concentrations in the body. So when we're talking about that, we're talking about salts and the fluids. They can become increasingly difficult to remove from the bloodstream, and this can result in edema and hypertension. So I'm sure you have patients in your mind that you can picture, the patients that come in and they have the real thin skin. It's usually really dry, and typically, they're going to have that dependent edema. So also a decline in kidney function can result in the decreased ability to remove metabolic byproducts. So this is when we're going to see high phosphorus levels. We're going to see those high creatinine levels. The big thing with phosphorus is that these higher levels can lead to a decrease in calcium levels. This triggers a whole hormone response. So when you have those decreased calcium levels, then you're triggering the parathyroid glands to release more parathyroid hormone to stimulate the release of calcium from the bones into the bloodstream. So these people have chronic calcium issues, and so this is something that we definitely need to make sure that we are monitoring. So patients that have more of a progressed chronic kidney disease, a lot of research actually suggests doing a renal profile or a renal panel rather than doing just a plain complete metabolic panel, because you want to make sure that we're monitoring the magnesium levels, we're monitoring the calcium, we're monitoring the phosphorus levels, and those are all included on that renal panel. And we'll talk about this in one of the later modules when we go over labs. Another important side effect of chronic kidney disease, just to make sure that you are aware of, these patients will typically be chronically anemic. And what happens is we'll see this in the later stages of the disease progression. But what happens is there is a decrease in the erythropoietin production, and it causes a reduction of red blood cell production. So these are people that near the end stages, a lot of the times we are having to give them blood, but at the same time, we have to be really very cautious when giving them blood, because we don't want to fluid overload them as well. And some of these patients will be on dialysis, and that adds a whole nother complicating factor to it as well. So we want to try to prevent the progression of chronic kidney disease as much as possible. So taking a look at epidemiology, because I always think this is interesting, according to the National Institute of Diabetes and Digestive and Kidney Diseases, some level of chronic kidney disease can be seen in 1 out of every 10 adult Americans, and chronic kidney disease is noted to be the 9th leading cause of death in the U.S. So chronic kidney disease prevalence increases significantly with age, occurring in approximately 4% of adults aged 29 to 39 and approximately 47% of adults over the age of 70. The most rapid growth is seen in patients over the age of 60. So if you guys, if you were listening to me as I was reading those statistics, one thing that I, thought that was interesting was that they said that it occurs in approximately 4% of adults aged 29 to 39. For me, I feel like that is just so young to start having some chronic kidney disease. But if you think about our obesity rates and the rate of patients being diagnosed with diabetes and high blood pressure, for a lot of these diseases, we're seeing that people are being diagnosed in the mid-20s. So with that comes some of these other conditions. So that's why it's important to really make sure that we're monitoring our patients closely and catching any of those, just those little triggers in their lab work that might show us that something else is occurring. So if we look at risk factors for chronic kidney disease, there's modifiable risk factors and non-modifiable. And I know you guys have heard over and over, what that stands for. But basically, modifiable risk factors for CKD would be diabetes, hypertension, NSAID use. That's a big one as well. A lot of people use NSAIDs, and many of them do not understand that this can cause chronic kidney disease over time. And then history of acute kidney injury. So somebody that perhaps becomes dehydrated often, and you can see this a lot in athletes actually, where maybe they're not replenishing as well as what they should. They will have multiple episodes of acute kidney injuries, and they may be small episodes, but over time that causes damage, and later on we can see them develop chronic kidney disease. Some of the non-modifiable risk factors include family history of kidney disease, age 60 or older, and then ethnicity. Now, I don't know about you guys, but I love these pictures things, and I think it is so much easier to look at one of these and remember it rather than reading off of a slide. So this picture specifically is more end-stage renal disease. So you're looking at a GFR level, and we'll go over what that is, but we're looking at a GFR level lower than 15. So a lot of these people are withdrawn, they're depressed, they're going to have the anemia that we were talking about. A lot of the times their potassium will be elevated. Like we were talking earlier, they'll have that dry, flaky skin that typically is very thin and prone to breakdown. They'll usually complain of cramping in their legs, sometimes even in their back and their arms. A lot of them will have bone pain. Some of them also will constantly complain of a metallic taste. A lot of the times when I was working with chronic kidney disease patients in palliative care, that was a huge complaint, and I never realized how big of a complaint that was until I worked with them on a frequent basis. A lot of them will be anorexic. They really just won't have an appetite. They'll chronically be nauseous, and this will be worsened if they're on dialysis. A lot of them near end stage, they will have elevated blood pressure. They'll have pitting edema. They're more prone to pericarditis as well, and pulmonary edema. A lot of them have a chronic cough as well. So all of these are things that, even though they're more prone in the end stage renal disease, we'll see them develop over time, and it's important to catch on to those little things that are changing in our patients. So what is the diagnostic criteria for chronic kidney disease? So typically we have to see abnormalities in the kidney structure and or the function, and that has to be present for 3 or more consecutive months. And then we need to see some sort of implication for health. So are they being hospitalized more often? Are we seeing a drop in their hemoglobin? Are we seeing a chronic anemia develop? Are we seeing changes in their skin? Is their blood pressure elevating? Are their sugars out of control? These are all things that we could document to show towards that diagnostic criteria for CKD. We also, when we're looking at lab work, these are the things that need to be present as well. So we need to look at the GFR. It needs to be less than 60 for us to start diagnosing chronic kidney disease. We need to look at the albumin creatinine ratio, if I can say that right. That is typically greater than 30. And then markers of kidney damage. This can be looking at the calcium levels. We can look at the phosphorus, the magnesium. A lot of the times the magnesium and the phosphorus will be elevated, and that also includes the potassium. And then, like I said earlier, the calcium will be decreased. But those are all markers that could be included when you are trying to make a case for a diagnosis of chronic kidney disease. We also want to make sure that we're getting a urinalysis. So we can see that there might be some hematuria that might be happening periodically. Some people will also go and get a kidney biopsy as well, especially if they are perhaps suspecting more of like a polycystic kidney disease, and that'll be seen on CT scans. And we'll go over that as well too in the lab work and imaging diagnostic module later in this semester. Now, I will tell you, this is a slide that you want to make sure you print off the notes that I have included for this slide, just because I put quite a few notes, just because it was just way too much to put on a slide. So how we diagnosed kidney disease and how we rank what stage it is, we go off of the GFR. So the GFR is the estimated glomerular filtration rate, and it lets us see into what the overall kidney function is. Okay, so the ACR, or the albumin creatinine ratio, is also important in determining the extent of kidney disease or damage. At the end of the day, the GFR is what stages it. So that is the most important test when you are trying to diagnose someone with CKD. And it's really important when you're diagnosing that on their note, you're not just putting CKD. We want to know what stage it is. So I have on here in the notes section stage 1 through 5. Stage 5 being kidney failure. Stage 1 is the very beginning. So make sure this is something too that you can print off or keep with you when you're documenting patients, but you want to make sure that you know what GFR rating equals what stage. Also, something important to note is that in stage 1 and stage 2 of chronic kidney disease, the GFR alone should not be used to diagnose CKD because in those stages, the GFR is typically, it's greater than 60. So it'd be between 60 and 90, and that's typically considered borderline normal for some. So in these cases where you have someone that you're suspecting that they might be in stage 1 or 2, you need 1 or more markers of kidney damage just to determine that diagnosis or to finalize that diagnosis. So we can look at, is there any urine sediment abnormalities in the UA? Are there other electrolyte or other abnormalities related to tubular disorders that they could have? Is there any structural abnormalities? So we can do this by getting an ultrasound of the kidneys or a CT scan. And then also another important one is there any history of kidney transplantation? Because that obviously is a big risk factor for kidney disease. So just keep that in mind when you have someone that you're suspecting stage 1 or 2. You need to include other information to show why you are thinking that they have those stages of chronic kidney disease. The more common stages that you guys will see documented and that I see a lot, as far as the patients coming into the hospital, you'll see stage 3A and stage 3B. Just that is the only stage that is separated into A and B. But stage 3A is moderately reduced, and that GFR would be between 45 and 59. And then stage 3B is also considered moderately reduced. However, the GFR level for that one is 30 to 44. Stage 4 is considered severely reduced GFR, and that's 15 to 29. And then stage 5 is considered kidney failure. So it's a GFR less than 15. These people are typically on dialysis at that point. Now, keep in mind when we're talking about the GFR that a normal GFR does vary according to age, sex, and body size, and then it will decline with age. I did include a calculator there for you, although I know Lindsay and I have told you guys what we use as far as in our own practice. I like the MediCalc. That way I don't have to go to multiple different websites to calculate things. But just so you know, the National Kidney Foundation actually has a lot of really good information about kidney disease, and they have information for patients and they have information for providers. So I included that on there so that you guys could, go and look at that information as well. The albumin creatinine ratio, it can also be known as the microalbumin level. They abbreviate it by saying ACR or UACR for urine, or they'll call it the urine albumin level. So just depending on what lab you use, just make sure that you know that that is the same thing. The ACR is typically completed upon diagnosis of diabetes or hypertension. So just make sure that when you first diagnose somebody with diabetes or hypertension, you need to also get that level. And then typically it's done yearly after that, because that is what's going to show us if there's any diabetic nephropathy. So we want to make sure that we catch that early on. And then typically a routine urinalysis is performed yearly in adults. And most primary care providers, I would say, are good about doing this. And it's nice if you are working in primary care, it's nice if you are able to collect this in your office rather than sending someone, because I guarantee you if you send somebody to go and get a urinalysis, a lot of people will forget. So just just keep that in mind when you're in your own practice. If the urine dipstick is positive for protein, the albumin level is already greater than 300. So you want to make sure that you follow up with a quantitative urine protein. And this is something that's just recommended by the American Diabetes Association. Another important piece of information to note is that when you are getting a urine sample, it's really the best way you can get a urine sample is for it to be the first morning void, especially if you are doing a 24-hour urine test. That one, if you are in the hospital, we can do different testing as far as urine tests, which makes it really nice, because at home you're really kind of limited because obviously that person isn't an easy access to you. But if you have somebody collecting a 24-hour urine, you can also pull separate samples from that, as long as you're not having them go right into that container. But there's different levels and things that we can check, and that first morning void actually gives us a lot of great detail. So depending on what test you order, make sure you understand if that is a requirement for that test. Bringing the GFR and the ACR together, here's just a nice little graph for you guys. You can print this off, you can keep it with you in your pocket if you want, but this just goes along with the staging for chronic kidney disease. So chronic kidney disease and patient safety. We've talked about this a little bit here, but I wanted to just take a moment to focus on that. So these people they can very easily become toxic from different medications, especially if medications are being excreted through the kidneys. We have to be very, very careful. So a lot of medications, when you're looking at especially antibiotics, and we'll talk about this in a later module as well, but a lot of them have to be renally dosed. And so that is something to always consider before you prescribe a medication. If you aren't sure, this is a good time to make friends with a pharmacist, or you can get on Hippocrates or something of that nature, so that you know if that medication needs to be renally dosed. A lot of these people also need to be monitored a little bit more closely because of their risk for toxicity. So keep that in mind when you're scheduling a follow-up appointment. We also need to do more frequent lab work because they are more prone to hyperkalemia, hypoglycemia, and then like what we were talking about earlier with the phosphorus, the magnesium, the calcium, all of those. So all of those electrolytes need to be monitored closely. These people are also more prone to multi-drug resistant infections, especially if they have any sort of fistula or line placement. We want to try to protect those as much as possible. So this is a really important time to do that patient education on proper hygiene and care of whatever they have. So whether it be a fistula or a line, we need to make sure that they know how to properly take care of that. Continuing on with patient safety, we also need to always have safety in the back of our mind when we're ordering imaging studies. These people are very prone to developing an acute kidney injury if you are using contrast. So just keep that in mind. The other day this happened. Actually, we had a patient that we suspected a PE, and his GFR was just right past the line as far as the cutoff limit for when we could do a CT scan with contrast. And so we kind of knew that we would have to watch him very closely, and he did. He went into a mild acute kidney injury after that. However, we were able to determine that he did have a PE, and we were able to treat him appropriately. So in that case, it's more of a risk versus benefit type situation, and that's something that you need to do with every single patient because they are just so prone to developing those AKIs. You also want to be careful when they're going for any sort of GI procedure where they have to be cleaned out prior to it. That sodium phosphate bowel preps, they can also cause acute kidney injury in patients with chronic kidney disease. And a lot of the times, if we're not careful and we don't catch those AKI events soon, it can develop a further progression of their CKD. We also want to make sure that we are monitoring these patients for cardiovascular disease. And we talked about this earlier. One thing in particular that I notice a lot in the hospital is that these patients do not always have chest pain. They might have some other symptom, maybe some acute back pain or a headache, or one really interesting patient, I had a patient that just had these hiccups and could not get rid of the hiccups, but never had chest pain. And they chronically have elevated cardiac enzymes because of their chronic kidney disease. So that's one thing to always make sure that you kind of take note of, is that you can't always rely on the cardiac enzymes, specifically the troponin, because they will always be elevated in these chronic kidney disease patients. For these patients, the hiccup patient in particular, we kind of exhausted all of our testing, and one of the kind of the last ditch efforts that the cardiologist did was decided to do a heart cath because of the patient's high risk factors for cardiovascular disease. And they actually found, I can't remember exactly if it was, I think it was a 90% blockage. I mean, it was a decent blockage. So the patient ended up getting a stent. But, that at the end of the day, that patient never had chest pain. If I remember right, there was only mild EKG changes, but they had had previous changes in the past. So there really wasn't a huge any huge red flags basically saying that this patient might be having a heart attack or might have severe cardiovascular disease. And it's all because this patient had, they had stage, I think 3B or stage 4 chronic kidney disease. And so it kind of masked this cardiovascular disease. So keep that in mind. These patients also need to be watched for fluid management. So a lot of them sometimes will have periodic hypertension, but they can also have hypotension. They're more prone to acute kidney injuries, and that typically stems from being dehydrated. If they also have concurrent congestive heart failure, they can also develop exacerbations pretty easily as well. So what do we want to tell these patients to keep them safe? We want to tell them to avoid NSAIDs. This is a big, big no-no for chronic kidney disease patients. And, a lot of them, like I said, a lot of them use ibuprofen because when we go back and talk about the calcium, that eventually can develop bone pain and things like that. So a lot of them, they like the anti-inflammatories. And so a lot of them will take high doses of ibuprofen. So we need to make sure that we educate them appropriately. Any med that has a 30% renal clearance, it really needs to be renally adjusted. And you can call pharmacies to get that renal dosing. You can look on Hippocrates. All of that will be at your disposal as far as, with a pharmacist. And that's the nice thing. If you actually, I have a nurse practitioner friend that, has all of these great apps, but with where she's located at in Chicago, she doesn't really have good service. And so half the time she cannot even access her apps. So whether you have apps or not, it's really good to develop a friendship with one of your local pharmacies so that you can call them and ask them these questions. And then again, we want to make sure that we're careful with any contrast, any biphosphonates. We need to be careful with all of that. We discussed the medications a little bit in the previous slide. One thing I just wanted to note here is that you want to try to minimize pill burden as much as possible. A lot of these patients, because a lot of them have a lot of other comorbidities, it's not just always the chronic kidney disease that they have. They end up being on a lot of medications. So if that is one thing that you can do as their primary care provider, is get them off of some of their medications, I guarantee you that they will be much better off. So really try to take away what you can. If they don't absolutely need it, then get rid of it. Monitor their blood pressure, encourage them to maybe lose a little bit of weight and be a little bit more active. If you can get them off some of those blood pressure medications, that is going to be better for them in the long run. These next two slides, I want to talk about when you should make a nephrology referral. I know we talked about that in the beginning as well. A lot of people, by the time they're referred to nephrology, they're in the later stages already, and you can't go back. Once that kidney disease progresses, there's no going back. So these, I'm going to give you some, some times when they should definitely go to nephrology, but this isn't a concrete list. So you can always send a person sooner, even if the nephrologist sees them once and they're aware of them and then says, follow up with primary care. If you have any more issues, call me. That's fine. At least they've had a nephrologist look at them and they will have someone to go to in the event of an emergency. So there's nothing wrong in doing that. But definitely, if a person has a pretty severe acute kidney injury and they have to be hospitalized for it, you want to get nephrology's input. If their GFR is falling below 70, if their ACR level is greater than 300, if they have more of an atypical progression of CKD. So that means that, and I highlighted this, that means that maybe you've noticed that maybe the past couple of months they've had some markers for kidney disease, and then all of a sudden now they're meeting the criteria for stage 3 or stage 3B, say. That definitely should be an indication for a nephrology referral because something else is going on and we need nephrology's input. If you notice that other lab work is off as well, and it's trending to be off, then lost my train of thought. If you notice that, let's say an anemia, so their anemia is not getting better and you have related it back to their chronic kidney disease, that would be another indication as well. So any lab work that is trending and it's a marker for kidney disease, that would be an indication to refer. Last slide here. So any hypertension that's refractory to the treatment, they're on 4 or more antihypertensive agents, I would argue that they would need to see a cardiologist as well for that. But if it's stemming from their chronic kidney disease, then they need to have nephrology involved as well. If they have persistent abnormalities with their potassium, if they have chronic or reoccurrent kidney stones, or if they have a hereditary type kidney disease, then those would also be indications for a nephrology referral.